statewide. Mental Health Action Partnership is a statewide mental health coalition, a very broad coalition across the state, across the lifespan, across the continuum of care. And we're working on to sustain continued improvement in mental health care delivery throughout Wisconsin. So these learning sessions are an opportunity for us all to tool up on things we need to know. This learning session in particular, there are a couple of goals. The first one is to help all of us understand what we need to know about the importance of Medicaid in mental health care delivery in Wisconsin. And then the second one is this is kind of a pilot of a training session that any of you who are so inclined can take and educate the people in your networks about Medicaid and mental health. So our wonderful presenters are going to talk to us about this today, and then we'll kind of take it back and revise it and create some materials and create a training session. And we will invite any of you who are so inclined to become trained to present these materials. So if you're interested, you can email Julia Polk, who will put her email in the chat, and we'll let you know probably a little later in the summer when this training session begins. So I think we have a lot of people on the call here, probably expecting some more. These learning sessions are interactive. What we're going to do today is we're going to have our presenters present half of their materials essentially, and then stop for questions, and then present another half of their materials approximately and stop for questions. And then we're going to go into some breakout sessions where we have some discussion questions, and you can chew on this material and, you know, find out what's still a little fuzzy for you, what you want to know more about. Just thinking about, if I'm going to learn this material and or teach this material, what else do I need to know? So then we'll come back together and we'll just chat a little bit as a whole group, and then I'll send you off into your weekend. So with that, I'm going to introduce our presenters. Kathy Markeland is the Executive Director of the Wisconsin Association of Family and Children's Agencies. They're providers who serve children and families throughout the state of Wisconsin, and they provide a lot of Medicaid services. And then Sashi Gregory is the Public Policy Director for the Wisconsin Primary Healthcare Association, which are the federally qualified health clinics throughout Wisconsin. They are wonderful presenters, and so I am going to throw it over to Kathy to get started. And Kathy, should I start sharing my screen now? Okay, let's start sharing.
Yes, please. Please do, Sita. This is it.
Kathy, you're breaking up.
Am I breaking up?
That's better.
Can you hear me now?
Yeah, that's better.
Okay. Okay. Thank you, everyone. And this has been a bit of a humbling undertaking, I will say, for myself, if I can speak on behalf of Sashi also. It's a big topic to think about. How do we try to create something that shares forward an overview of Medicaid that represents where Medicaid fits in our mental health care services delivery system in Wisconsin. So let's go to that first slide, Julia. As Sita said, we broke this down and just try to do it a who, what, where, when, why, how overview. And so as we walk through the slides today, we'll be approaching it from that sort of frame and trying to provide for some essential understanding within each of these pieces. We looked at this and think about not only the who of who is covered, but also thinking about the how of service delivery, so that it is one thing to be eligible for a service, it's another thing to actually have access to a service. And so to understand this both through the lens of those who are receiving services, the recipients and consumers who are enrolled in Medicaid, and then the providers and the networks that are out there, and our MCOs and our payer groups, and how those pieces intersect with each other to actually result in a mental health service treatment delivery in Wisconsin. So let's jump to the next slide. Let me just contextualize too that if we can't answer all of the questions today, we may not be able to. We probably won't be able to answer every question, and that's okay. And we're really interested in the things that are going to come up for you all, as Sita said. Sashi and I both come from a provider perspective, different kinds of providers, but we certainly bring a certain lens to how we look at this information. And certainly if our county partners or if a state had been presenting this, they might have put the information together in a different way. And so we're really eager to get that feedback and have our conversation through this. But let's start with a little bit of kind of level setting around why Medicaid is so important for our mental health services delivery system here in Wisconsin. It's important to note that Medicaid is really the single biggest payer on a national basis for mental health services. And I think that's something that maybe people don't appreciate. It's also an increasingly substantial payer for substance use treatment, right? And we think about these mental health and substance use treatment services under a singular umbrella. In fact, you'll often hear us talking today, I think, talking about mental health services, and we certainly include both substance use treatment and mental health services within that umbrella. We do know that within a Medicaid payment system that may look differently for those two service lines on some level, but we are increasingly moving towards an integrated approach to co-occurring conditions in a state. Noteworthy that nearly 40% of the non-elderly adult population enrolled in Medicaid has a mental health or substance use condition. That's a substantial percentage if you compare that to the number of people who have private insurance or commercial insurance who also report a mental health or substance use condition. So it's really emphasizes the point that really Medicaid, the service delivery, primary service delivery mechanism for serving people who have mental illness or substance use treatment needs. In Wisconsin, we use this term Medicaid, so here's a really good level setting point. It's also referred to as medical assistance, or MA, you'll hear that reference. Also Badger Care Plus, and we'll talk a little bit more about how we differentiate between what the different programs are that we have available under Medicaid. But that's Badger Care Plus, or our general Medicaid, medical assistance. It's really a key source of funding for a full range of services for individuals with behavioral health conditions, including the serious mental illness components. And oftentimes when we get into serious mental illness, as we'll discuss further on, we're starting to talk about other programs that people become eligible for under functional screens. So really, when we think about it, and I like to cover this full array here, right? We'll be talking today about school-based services to recovery services to crisis services. Medicaid is really a fundamental building block of our systems of care for children and adults in needs of mental health treatment and supportive services across that full continuum. And so now I'm going to kick it over to Sashi.
Great, thanks, Sita. So I'm just going to go back to basics for us on what is Medicaid. Sita, if we can get to the next slide. So, you know, Medicaid is really the primary program that provides kind of the biggest array of coverage for 80 million low-income people in the United States. So that's about 1 in 5 Americans or individuals are covered through Medicaid nationally. So it's a big population. It's kind of a big source of coverage and of healthcare for people throughout the country. Next slide, please. It's also the major source of one of the major sources of funding in our national personal health care system. So once again, about 20% or 1 in 5 of all spending is funded through the Medicaid program. And then when you go to long-term care, that's even bigger. So nearly half of long-term care services and supports in the United States are funded through the Medicaid program as well. So it's a big part of our national budget as well as our state budgets too. Next slide. I think a really important part of the program and how it was designed is it's a federal and state partnership. So it's jointly financed by states and the federal government. And, you know, there are basic federal rules that states have to follow, but each state Medicaid program is unique. So, you know, once you've seen one Medicaid program, you've only, you know, you've seen one. So every state, kind of depending on their economy, depending on their politics, depending on just kind of what they look like in terms of demographics, is going to have a different Medicaid program. And, you know, eligibility, benefits, coverage, you know, special programs, that's all going to kind of look different for each state. I think because the states have this flexibility, and we talked about this, it's just, you know, you can learn a lot from other states as well. And I think that's something that we can, you know, generally, you know, work towards too, as we talk about later about what are some innovations and things like that. So Medicaid also kind of allows for this flexibility to kind of experiment or do demonstration projects, and you can see those demonstration projects across states. And so I think that's a unique part of the program. The map there on the right just kind of shows the percentage of population covered by Medicaid. And I think this also speaks to kind of the difference in Medicaid and the variation across states. So Wisconsin, about 18% of our population is covered. That's kind of right in the middle for all of the states. And then you can say Utah's the lowest coverage, and then New Mexico has the highest coverage of folks at 34%. So this is all just really depending on how the state has designed their Medicaid program. Next slide. All right, so like I said, funding is a huge part, and like it's the government's share of most of Medicaid expenditures is called the federal matching assistance percentage. So we call that the FMAP, right? And each state kind of has their own FMAP, and it's designed by the federal government according to, you know, the special formula, so that the federal government pays a larger portion of Medicaid costs in states with lower per capita income. So for poorer states, for states that don't have as much, you know, tax revenue coming or income revenue coming in, they will get a larger kind of federal matching percentage rate. So you can't get lower than 50%. So there's a few states that have 50. I think, and I think the highest is, you can't go over 80 something percent. So there are some states who have fairly large ones. While this is pretty consistent, you know, during times of recessions or during COVID, there were like special ways that helps the federal government would use the FMAP as an incentive for states to cover more people or to keep people on. And so they would increase the matching percentage. You would get more of, you know, the dollar that you were spending on Medicaid's covered by the federal government. So currently we are at, the federal government pays about a little bit over 60% of the cost of Medicaid here in Wisconsin. And then I have a little piece there that just shows kind of how much the federal government is spending in terms of the total budget for Medicaid. Right, next one. Okay, I think this is an important slide because state budgets are a big part of kind of how Medicaid programs are designed and what happens with Medicaid. So as you can see to the right, Medicaid is the second largest spending category, so right after education, for Wisconsin's general purpose revenue. So the revenue that's exclusively from Wisconsin taxes and sales tax. And so I think, you know, it's just important to know as we come up to the budget process coming soon, that this is going to be a big discussion point of like what eligibility looks like and what things look like in Medicaid and how much that is a part of the budget. And so, you know, just really understanding how the program really influences the budget is good too, because not only is it like a spend, but because of the large kind of portion of federal money that's you know, given to states, it's also a bit of a revenue as well when you think about the federal money coming in and how that can support further services. All right, so one thing is that in terms of the percentage of who is enrolled in Medicaid versus where the spending is going is kind of opposite. So for adults and children, so most of the individuals who are on the Badger Care Plus program, that's only about 44% of all state spending on Medicaid. Whereas for elderly and disabled individuals, that's over 50% of Medicaid spending is going towards that group, which is only, a little bit over a quarter of who's actually in the Medicaid program in the state. And then to the right, it just kind of shows for all of the Medicaid spending. So this is the 10.4 billion, which is both federal and state funding all together. A large portion of it is going to managed care, which includes the Badger Care Plus program, as well as a number of the long-term care and support services. And then you can see in the lighter blue areas, those are the fee-for-service programs. So Kathy will talk about this a little bit more, but the way individuals are reimbursed or how the program works, it can either be through a managed care organization or sometimes through a fee-for-service piece. And so the majority of the spending is kind of going through these managed care organizations. Okay. So this one just shows that, we talked about how each state is unique and how each program is unique. This slide just really shows that, Wisconsin is one of those states where employee sponsored insurance is actually quite prevalent, right? And so there's a lot of a slightly larger portion of the insurance coverage is through employers. And I think I'm just pointing that out just because it shows why Medicaid programs might look different in different states. And then I think one thing it shows that, with adults with any mental illness in the past year, the share who have private insurance is kind of larger than those than the average in the United States for Wisconsin individuals who have private insurance. Okay. Medicaid and mental health. I'm going to move this on to Kathy, and she's going to kind of take us through this, and then we'll go from there.
All right, am I back? All right, great. So again, a couple of times through this presentation, you hear us sort of return to contextualizing a little bit more about why Medicaid matters for mental health. And so this is really, as we think about the kind of fundamental building blocks and the reasons why Medicaid is important. And we really think about it, I try to break it down into threes. Threes is a magic way to think about things, right? We tend to, works well for our brains. But one is that coverage. So Medicaid is important because it provides coverage. It funds networks of access for children and adults who lack employer-funded health insurance. That seems obvious, but not necessarily. We do still have people who are uninsured, and among our Wisconsin community. But we really do have the majority of our folks covered in some way, shape, or form, either through a commercial plan, through the healthcare marketplace, or through Medicaid. But it's really this way of ultimately capturing and caring for that group of individuals who are not able to access care through an employer-funded plan. Equity, it provides a more equitable means for financing mental health services than some of our historical heavier reliance on county funding. And as we continue to talk about our Medicaid services delivery systems, you'll see that county component come in a little more strongly because of the county-based responsibilities for caring for people with mental illness and substance use treatment needs. But when we think about where that expense has been carried historically, that there has been a heavy reliance on county levy and county funding resources, and there's great disparity across our 72 counties in their capacity to pay. And so where Medicaid has come in and been increasingly a player in supporting Medicaid services delivery, that has really helped to, in a way, it helps to level the playing field and create a more equitable financing system. And then innovation. This is something that I think is important to emphasize, that Medicaid often is a leader in healthcare innovation and in exploring new coverages. And some of the examples that we're calling out here today, really thinking about where Medicaid has led on peer specialists and peer respite. You do not see a lot of commercial insurance stepping into that space to cover peer specialists at this point. So that's really an expansion of thinking about who can be reimbursable, who can be a service provider within the mental health care space. And the expansion to peer specialists is a great example of how we start to innovate and create new opportunities for service development among providers. A few other examples here: in-home therapy for children and families. Wraparound is a familiar term to me, but really a unique model for being able to deliver a full array of really unique and flexible services to children and families and individuals who have higher level needs. And then coverage of social determinants of health related wraparound services. So increasingly seeing where across the country and in Wisconsin as well, where we're adopting some housing coverages as a component of Medicaid, where we're starting to look at how we can more, again, flexibly use a mental health dollar to really think about that social determinants of health element. So, I just want to keep that in mind. We'll return to this again as we think about where the opportunities are looking forward. Next slide. Oh, time for questions.
Everybody, we just wanted to pause here because we've thrown a bunch of information at you. And if you have a question, you can just raise your hand, your real hand or your Zoom hand, or put it in the chat. Dr. Imler, I see Rick Imler there.
Thank you. This is great. Will there be a discussion about the impact or lack of impact of Medicaid expansion? You go on.
We will dip into that a little bit, we certainly, again, I think it's an area where we could do more within the context of the presentation. So eager to do that, some more conversation about it too at the end.
Thanks. Any other questions before we move on?
That's a good question, Lisa, on who has the highest reimbursement. We'd have to get back to you on that. We don't have that number on hand at the moment. And it definitely depends on the providers as well. So.
All right, I think we will go on. I'm going to share my screen again. We'll proceed.
All right, so I get to pop back up again and talk about eligibility and kind of the benefits covered. All right, next slide. Okay, so who is covered? Well, Wisconsin kind of mirrors nationally kind of what coverage looks like generally. And so the biggest group is children. So 1 in 3 children in Wisconsin are covered through Medicaid. And then the next 2 bigger groups are nursing home residents, as well as people with disabilities. And then we get to adults, and then Medicare beneficiaries, or folks we call dual eligibles usually. 44% of the non-elderly Medicaid enrollees in Wisconsin are people of color. And then 68% of adults in Wisconsin are actually working and on Medicaid. And all these pieces kind of come into our conversations as we talk about, or as the state talks about different coverages and different ways to kind of have people on the Medicaid program. Another important part is about, and this is, I think Wisconsin's a little bit lower than nationally, but 34% of births in Wisconsin are covered through the Medicaid program as well. So the coverage of pregnant women and the coverage of the births are all really kind of a big portion of Medicaid and that access to prenatal care. And I think, we'll talk later, about the 12-month postpartum coverage discussion that's been going around. Wisconsin's still not quite there. I think we're one of the last 3 states who has not kind of expanded that coverage yet. All right, and then this one's just to show you once again, and I think Kathy got to this a little bit earlier when we were talking about county funding, but also, there's just differences in who's covered by Medicaid in counties. So the lowest percentage enrollment is in Ozaukee County, and then the highest is in Menominee, where, gosh, nearly 70% of individuals are covered through their program. And this is just based on population. It's based on just barriers that people might have to like knowing about enrollment or being able to enroll. And I think, it's just important to see that there are differences across counties, and that's also affecting kind of the mental health piece as well. Funding as well. All right, next one. Okay, so this is a graphic that was actually made by Kids Forward, I don't know, maybe like 12, 13 years ago. And it's just a great graphic that shows kind of by eligibility group, kind of what the eligibility income levels are. And then it also shows not just Badger Care, but marketplace insurance as well. So basically it's, what does eligibility for health insurance look like in Wisconsin for people who don't have employer sponsored insurance. And we do have this linked somewhere. So if this is something helpful for you, I know a lot of outreach and enrollment workers love to just have this in front of them when they're doing kind of a quick look at somebody's eligibility piece. But I think this is a nice kind of quick illustration of what the incomes look like. And so we'll get to this on the next slide a little bit more on specifics. And so actually we'll get back to that in a little bit. All right, so this is just a quick snapshot of what Medicaid enrollment looks like in Wisconsin as of May 2024. So the end of May. So every month at kind of the beginning of the next month, Medicaid will update their numbers for enrollment in their different programs. And this is, publicly available. It hasn't changed in terms of the percentage of who's on it. Like children are making up the largest percentage at 44%. And then like we talked before, kind of that elderly, blind and disabled and senior care and other pieces are taking up a little bit of a larger piece. All right, and then effective in January 2024, and this might affect what the enrollment numbers will look like this year, is that children will be enrolled in Medicaid for 12 months, so have continuous eligibility for 12 months. And so that's a new federal requirement, and the state just implemented that this past January, I believe. All right, so this one is just showing kind of a enrollment comparison of, the end of the middle of 2023 when we started to do the unwinding across the nation. So this is like the Wisconsin look. So in 2023, during COVID, the state kept everybody on Medicaid, right? You couldn't go off of it. You weren't asked for your income and whether you needed to renew. And then over 2023 and going into this, I think this month is the last month, states had to do what we called unwinding. And that was getting back to folks and getting back to seeing whether they were eligible. So they had to go through a renewal process. And this is something where we saw, a large number of people kind of falling off the Medicaid rolls. Some went into marketplace, some had employer sponsored insurance and went back to that. But you can see the numbers compared from July 2023 to May 2024 that they are lower. And so both for the elderly and disabled coverage, but really the bulk of it was for Badger Care Plus. So that's children, adults and caretakers, pregnant women. That was kind of the one where we saw a larger decline in folks. And some of that is due, like I said, to the fact that they had other insurance coverage, but also some of it is due to that they just fell off of the coverage because they either didn't renew or, they didn't send in their correct information. So that's something that the federal government, other policy folks are looking at closely of like kind of what happens next with all of these individuals who kind of got affected by the Medicaid unwinding. Okay, so this is going back to the Badger Care Plus eligibility and benefits we were talking about. So that chart before that just kind of showed like children, pregnant women, elderly and disabled, that this is kind of that eligibility for Badger Care Plus. And so I won't walk through this, but Wisconsin does have one of the higher income levels for children in terms of eligibility. So that's 300%. So if you're under 300% of the federal poverty level as a child, if your family's under that percentage, you get to be on Medicaid. We also have adults under the age of 26 at any income level who was in a foster home or in foster care. They also are eligible for Medicaid. A parent or caretaker of a child is eligible if their income is under 100% of the federal poverty level. And then also adults who don't have children have that same eligibility income level as too. And then the income level goes back up for pregnant people. So that's back to kind of what kids are eligible at. So the benefits in Wisconsin are actually quite generous. So we have all the mandated benefits, and then we also include some ones that are optional. And so I think dental is a big one. And that's a pretty a good coverage for children as well as adults in the Badger Care system. So that's just quick and dirty on the benefits. And then the did you know, and we talked about this earlier, that more than 90% of Badger Care Plus enrollees are in managed care organizations. And Wisconsin's extremely unique in that we have 14. I think that's probably the highest number of managed care organizations that the Medicaid agency as well as providers kind of have to deal with. So that's just something that's unique to Wisconsin. All right, so the next few slides, I wanted to kind of walk through what it might look like for different populations with Medicaid coverage, kind of going through the system. So this first one here is a 3-year-old and a mom, and they're going through their annual well child visit at their primary care office. So the child is eligible for Badger Care and they're signed up, but the mother is uninsured. So their family income is approximately, $5,200 a month, and that's for a family of 3, and that's less than the 300% federal poverty level. The child is Badger Care Plus eligible because they are 3, and their income is below the threshold. The parent's not eligible based on income because that income level is over the 100% federal poverty level. So what happens is the child comes in, the clinic provider does a well child visit and also does a depression screening for the mother. And the mother score is greater than a 9, let's say it's on the PHQ-9. So a special benefit, and I think this was maybe 6-7 years ago, as part of a child's well child visit and under what's the EPSDT benefit, that very special benefit for children, Medicaid covers the provision of a depression screening for the mother. So what would the Medicaid service look like? Well, one, it's covering that depression screening for the mother under the child's Medicaid coverage. And then it's also covering any benefits that the child needs that for medically necessary treatment and service needs. So whatever they are identifying as part of that well child visit, if the child needs, OT for something or needs, other care, that is covered for the child. So while the mother's care is not covered under the child's Medicaid coverage, what the screening allows is that the PCP can connect the mother with care. So a regular PCP clinic can help connect the mom with behavioral health services that she may need. A kind of cool thing, and I'm speaking from the federally qualified health center lens, is in an integrated behavioral health clinic at an FQHC, they can actually provide the mom with a warm handoff within the appointment. So behavioral health consultant can come into the appointment right after they've had the well child visit and do a quick session with the mother and kind of go from there. And this would be on a sliding fee scale. So that was kind of one, and it's a little bit complicated, but I wanted to bring in how creative the Medicaid program can be to kind of cover services. The next one is Badger Care Plus and school-based mental health services. And this is a big conversation right now. There's a lot of money going into this. So a 12-year-old with Badger Care Plus, they're eligible, they're less than 19 years old, and their family income is $4,100 per month. So, you know, approximately 200% of the federal poverty level, so that's below the 300% threshold. Let's say a teacher at a school kind of observes there's some behavioral changes with the child, and they refer them to a school's social worker. The social worker can connect the child and family with school-based behavioral health services. And this can look different depending on the school and the school district. Sometimes it's through a school-employed behavioral health provider who is certified through DHS 35 to provide Medicaid-funded therapy, or it could be contracted out to behavioral health services. So this could be through a community provider, you know, private clinic, an FQHC that can provide that school-based mental health care. And this provider is also certified to provide that Medicaid-funded therapy. I think what's unique is that the child then can receive that service at the school in person and oftentimes virtually. And this just helps eliminate some barriers to access. So including timeliness of care and then transportation issues, no-shows, things like that. And, you know, it also helps that a student attending therapy, you know, on-site can reduce time spent away from the classroom. And often families are also connected with care too, whether it's family therapy or other things like that. And then what happens at the schools, and they can bill Medicaid for the services provided for the child, and the child has to have an IEP as well as Badger Care Plus. All right. So, you know, I mostly spoke about Badger Care Plus as a program that really is kind of the biggest program and kind of the meat, but there are certainly other programs for children and adolescents. And I think that Kathy can talk much more about these than I can, but just to let you know, this Badger Care Plus isn't the only thing, and it's kind of like the main services, but there are these special services to really provide that kind of more intensive and more specific care for some special populations. Kathy, do you want to add anything to this piece on kind of other programs?
No, I think it's good. We'll go into a little bit further on too.
Okay, sounds great. Okay, so I have one more kind of walkthrough of somebody with Badger Care Plus, and this is kind of moving up the age range. So this is a 60-year-old adult, and they're actually experiencing a mental health crisis. This individual is eligible for Badger Care because their income is less than 100% of the federal poverty level. So, you know, for an individual, so one person at $700 a month. And then, you know, they're below the age requirement, so that's below 65. So a crisis, you know, the person is experiencing mental health crisis. So a crisis intervention team or clinic is going to work with individual and family to stabilize them. And then hopefully they're going to connect them to services. So because the person's on Medicaid and they meet the functional requirement for the CCS program, they are then connected with the county CCS program. And then with CCS level services, there's also, you know, all the other kind of card services you would get with Medicaid. So that would include also the coverage of medical and dental services for the individual. So that's kind of just a adult version in the mental health space of how kind of Medicaid connects across the different levels of care. All right, so there was a question about school-based health in the chat.
Yeah, the question is school-based behavioral health different than providing counseling in schools? But you saw that an IEP is needed.
Yes, it is kind of another level of therapy up, I believe.
So I'm happy to jump in on that a little bit. I'll just share that, so when you think about school counseling, so there are school services professionals in schools that provide a number of supportive services, school social worker, school nurse, school psychologist, and school counselor. There is a special array in Medicaid of services that are called school-based services. That is a special grouping that includes counseling that can be a billable service. And again, the caveat on this is that that children will need to have obviously have to have Medicaid coverage and be qualifying for Medicaid coverage. And then they also need to have an IEP in order for the school to actually be able to bill for those services. So it is a specialized array. When we think about school therapy, so individual psychotherapy that may be provided to a child, so more of a treatment level intervention that happens most often would have to happen with a qualified licensed provider that is providing that has been licensed through the Department of Safety and Professional Services. That those individuals and that billing happens through that provider's Medicaid certification, which is separate than what is offered as a school service. As Sashi noted, that's frequently happening with a contracted provider, someone who is working adjacent to the school, in the school space, often through an agreement. And then there is option, and there are some schools that have actually employed therapists to provide for therapy, and then those individual therapists would need to be certified again independently with Medicaid. But that would be different than a school-based service, which again is a specific array that is approved, exists under Medicaid.
Okay, sorry, this is Shannon. I had asked the question. So we do provide that type of counseling in schools. I don't recall ever seeing that an IEP was needed before. And I should have specified that earlier, that it is psychotherapy that I was referring to and not just counseling.
That's great. That's a helpful clarification, Shannon. Yes, students do not need to have an IEP for billing for psychotherapy services that are being provided by licensed providers. It's only these special array of school-based services that's specifically identified, which include things like that would be familiar to you, like PT and OT, that are children with IEPs that uniquely need those, that have special needs that need those services.
Okay, thank you. I'll look into that a little bit more. Thanks.
All right, Kathy, I think we're moving on to you.
Yes, we are back to me. So while we have talked about Badger Care Plus a lot, as Sashi has covered, that enrollment and that MCO sort of base program and that coverage system that we have for, which is sort of our generalized Medicaid, we also do have another special enrollment category, which is for elderly and disabled coverage. So this coverage is actually available to individuals who have been determined to be disabled or determined to be blind, or are age 65 and older. So this is again a special enrollment category that is less dependent on the financial eligibility and more about disability status. Just to note in this slide, the primary thing we wanted to call out is that Wisconsin does also have a heavy investment in managed care for our community-based services in this space. So many of our individuals who are enrolled in elderly and disabled coverage in the state fall into one of our managed care programs. And so some examples here being family care, the PACE program, the Family Care Partnership, as some examples. And I just really wanted to provide for some numbers attached to that. Sashi shared previously sort of the expenditure differential when you think about the number of people enrolled, for instance, in Badger Care Plus more broadly. Again, it's more heavily a younger and population and children, and so the expenditures are relatively less on a kind of a per person basis. But as we get into this category of this categorically eligible elderly and disabled, and we start to think about the family care component, and I love that everybody's jumping in and translating all of our acronyms here. It's a lot of alphabet soup. But that really the takeaway here is to have an appreciation for the kind of the numbers of people that actually are receiving coverages under these specific programs. And let's jump to the next slide. And specifically here, when you think about the family care and related package benefits and think about that array, in many instances, the mental health and substance use services are effectively carved out. of these different managed care products for this particular population. So meanwhile, I've highlighted in this chart some things that are mental health and substance use treatment related, and that there are pieces that are covered within the service array that people who are eligible for enrollment in these specific service lines that can support their mental health. But many of these individuals would also, if they needed psychiatric hospitalization, for example, that would fall out of their family care benefit. And so that while they are enrolled with an MCO that has that holds the majority of their coverage, they would need to go out into what we call the fee-for-service environment to receive coverage for some of those other more intensive services, for example. So it's again one of those pieces to appreciate about our system when you think about what's carved in. We use those terms, carved in or carved out, from a service perspective. So there are elements, again, that in our family care program that are covered, that it's kind of important to note those. But it's frequently one of the challenges that we've experienced in our system is that the mental health, not the full coverage, it's not full parity coverage of all of the service array that might be needed. And that's essentially what we wanted to be able to cover under this. I see a note from Mary Kay to define IRIS participants. So I would need a separate slide to define through IRIS, but what I will say is that that is a separately self-directed kind of program that operates, that individuals may enroll in as an alternative to family care, but it does allow for a little more working directly through ADRC and being assigned a care coordinator. They actually work with selecting their own service array. I'm not going to go further than that into explaining IRIS, but it is a different pathway that people can choose to allow for a little more self-direction within their care, as opposed to a sort of a defined benefit that they would be offered through a more managed care kind of entity that the majority of folks enroll in through our family care system. And we're back at questions.
Who has questions about whose coverage? So I have a question. So if I am below the poverty line and I qualify for Badger Care, and then I have a mental health condition, and I go back to work part-time, I don't qualify for my employer-sponsored health care. So can I remain on Badger Care if I'm working part-time and my income continues to be below the federal poverty line? That's one part of the question. And then I start working full-time and my income just comes just over the federal poverty line. What happens to me then?
So I would need an outreach eligibility specialist to really answer this the best way. I believe if you cannot afford your employer-sponsored insurance, you can stay on Badger Care. There's some kind of rules of how assets and everything is calculated for that. Once you move over, there is temporary medical assistance or transitional medical assistance. So, kind of that bridge sometimes that you can stay on. I think there's like a limited time that you can stay on that. But that really is, I am not an eligibility specialist, so couldn't explain that really well to you, but I think that's kind of where it would move for that individual.
Thank
But
you.
With Medicaid, people churn on and off, right? So those mental health services can get disturbed, right? And so I think that's just another thing to know about this population is that, you're not just on Medicaid your whole time. There's a lot of like ups and downs as your income changes and things like that. And that does kind of affect your kind of long-term, status with your mental health provider or could.
And it's confusing for me because if I'm on Medicaid, I have a certain benefits that are covered, including my medications and my therapist and all of that sort of stuff. And then if I'm on my employer-sponsored insurance, those same medications might not be covered, and maybe my therapist isn't covered. So it's very confusing for me going back and forth from Medicaid to employer-sponsored insurance or the ACA plans. I see a question from Brad there, and then a question in the chat about 100 versus 300% of the federally qualified of federal poverty level. But let's go to Brad first.
Yeah, thanks, Sita. Well, first of all, these charts are extremely helpful, and being able to compare the different programs side by side is great. Gives me some ideas, but it's part of a question and kind of a point too. So just because you're eligible doesn't mean that you can access these Medicaid services. And the county sort of dictates who is able to provide the services. So there are services that at our clubhouse that we could be providing, like crisis stabilization, but we don't have a contract with the county to provide those services. So we are left with only CCS, and CCS has long wait lists. And as Sita pointed out, people go on and off of Medicaid and so forth. So, just at first glance, eligibility and access, we all know this, but I just wanted to make that point again.
Thank you, Brad. That's an excellent point. And, I think that's something to Kathy and Sita, we probably want to address that a little bit more somewhere. Sita, and then I did want to address your piece about, when you move off to the marketplace or onto employer-sponsored insurance. I work with a lot of our community health centers, outreach and enrollment workers, and that's something that they really work with somebody. So if they're moving on to marketplace, they're going to try to see like, hey, can I still stay with that provider? Is this coverage going to cover my medications and things like that? So, not everybody's getting that, but that it's recognized as something that's really important to help somebody kind of navigate that and have that health insurance kind of knowledge.
Thank you. And can you talk about the federal poverty level, 100 versus 300? And then I'll go to Susan.
I'll let Kathy take that one.
So I will say that there are some parameters that the federal government puts out around that, but on the whole, there is latitude for states to be defining where they choose to attach coverage. There are states that don't cover childless adults at all, right? That they opt not to do that. So in terms of those populations and setting those eligibility levels, as Sashi noted, we're relatively generous in Wisconsin with our coverage up to 300% for children. So that's, again, compared to make contrast to other states, which would be at 200%. But that is a state determination, and it is set by policy by the state legislature around what it is that we're going to approve. That's not something that the Department of Health Service can make modifications to. It is a legislative a kind of decision-making piece around the design of the program itself.
Thanks. And the actual federal poverty level is determined at the federal level, like how much one person can make and be at or below or above the federal poverty level, 2 people, 3 people. It goes up by income and it changes annually. So just FYI.
Correct.
Susan. Yeah, Susan, go ahead.
My ongoing concern is, how do people learn how to access various programs, and specifically in the situation that Sita was discussing, where maybe employment is possible, but then instead of the 99% of the federal poverty level, now you're making 101%. How do you even learn? How does one even find out how to navigate this? What are those resources?
I would say, and I think this is something that's a really great question, Susan, for us to think about how we add that back and add more of that information into this presentation. But we do have direct resources when you think about tools like benefits.gov, where you can go and figure out and have somebody help you navigate through that. Covering Wisconsin is our state-funded resource that provides for that channel of access to people to the marketplace. And they are all well attuned to where those transitional spaces are and where supports are available for people as they move up into the marketplace and out of Medicaid eligibility through that. And about, there's one question you understand where you are situated now. And there's another about how you help really think about that, those realities of that decision making within their life of what an employment decision is going to mean for them. And when they do become eligible for an employer plan, and how you articulate whether or not that employer plan has adequacy for you. And there are pieces of that would actually, you know, they're highly complex, right? And so the idea that we're supposed to individually, even with the assistance of some of the programs that are out there, navigate that. It's complex. And Medicaid is, from a benefits perspective, pretty robust and rich compared to what people are going to find once they enter the marketplace and enter an employer coverage, most likely. I look at this hand up.
We should do the last slides, but go ahead, Rick, with your question or point.
Thanks for mentioning early periodic screening, diagnosis, and treatment, which is actually a mandated Medicaid requirement, unlike many or perhaps even most of the state benefits. And maybe because it's a complicated question, we can hold this. I'm just wondering how we compare to using EPSDT to other states. So I'm comfortable waiting on that.
Okay, I think we will wait on that. That's an excellent question. But let's go on with the show here. We just have a little bit more information to cover.
Yeah, and I'll try to move through this piece fairly quickly. I think Brad actually provided a very good bridge for us on this into some of this next piece that we wanted to cover. So we started out sort of looking at where our eligibility and sort of that broad array of benefits may rest. We also wanted to talk about sort of the network and payer and provider side of the equation, because ultimately it does not matter if you are enrolled and have a benefit coverage if you can't actually access a service. And you need a provider, and you need a provider network, and you need availability of providers to do that. Next slide. So within this space, we're going to talk a little bit more deeply about one of the unique features of Wisconsin's Medicaid service array for mental health and substance use, which is that our counties play a significant role in accessing mental health and funding for our mental health and substance use treatment service array. And that's especially true for individuals with severe mental illness and those experiencing mental health crisis. And so over time, Medicaid funding really has become an increasingly important component of that funding flowing to counties to support these critical mental health services. Next slide. So this is a slide that's hard to read, but here's the primary message here. So eligibility and benefits provides people with coverage. Access to services depends on network of providers, and these are providers who need to be certified to provide Medicaid services. They need to be enrolled in qualifying networks, and they have to be accepting Medicaid clients at payment rates that may not be aligning with the cost of care. So there are stop points in each of those that may mean it is difficult for an individual to actually receive access to a service or to access the provider they may want. So I just some how that works, right? We noted that Wisconsin is unique. We have 14 MCOs. So as a provider, if I want to serve a client across in other parts of the state for telehealth, for example, I may need to enroll with 14 different MCOs, and they would have to accept me within their panel of providers and within their network. That's a potential barrier space. Family care, again, multiple MCOs. You have 72 different counties that are responsible for offering some of our specialized mental health and substance use treatment programs. And those, again, are another stop points. And as Brad was flagging, right, that a limited number of providers may be under contract or in the array that the county is offering. And so that can create a barrier and create a funnel that you have more limited access for people to be moving through. Next slide. I'm going to go quickly through this, but I like this graphic that we pulled up one of the DHS reports that they issue every 2 years.
Kathy, your sound is, yeah, good. Go ahead.
Thanks.
Sorry.
What's important on this slide is where we launched new Medicaid MCO systems. And so Wisconsin really finally moved, for example, to full family care in 2018. So these are just important points of development of how our program service array has evolved over time, and to just note where we've created new opportunities for people to enroll and where the managed care organizations play a role in our overall service delivery array. Next slide. So again, I'm not going to spend a deep amount of time here, but you know, we think about mental health services and they cross over an array of things. So we have some medical services that are offered for the treatment of mental illness and substance use disorders, like physician services, as Sashi referenced, psychotherapy, which is a standard one that we think about for outpatient services, for example, prescription drugs. They're all available for all MA beneficiaries. It's part of the essential package that's being offered to anyone who's enrolled in Badger Care Plus, and the non-federal share for that is paid by the state. Medicaid payment rates for these services can vary based upon different Medicaid HMOs. There's 14, as I said. So when someone's actually seeking therapy, they can, depending upon which HMO they're covered through, whether they're receiving that service on a fee-for-service basis through Forward Health, receiving that service or a community health center. All of those can have an experience, a differential kind of reimbursement that is provided to providers in those various settings. Other services are provided at the option of counties, as we've noted. In some of these cases, the county pays the non-federal share. So this is where we get into this section of something that makes Wisconsin unique, in that the county is actually a component of the payer array, ultimately, for some of these Medicaid-funded services. So some of those include targeted case management for more intensive psychosocial rehabilitation services. We'll have a separate slide on those. And then we also want to think about crisis services, which again are primarily delivered through our county mental health services delivery systems. And then inpatient hospital care is another really important place where Medicaid is a big player. I think the data that we had quoted to us most recently from WHA was that 46% of the inpatient psychiatric hospitalizations that happened among our hospital systems were Medicaid-funded hospitalizations. Next slide. So I'm not going to rerun through these again. I think some of these get into some of these more specialized treatment things that we need to be aware of, though. Day treatment, for example, in this array, you actually have to be identified through health check as a child. Health check is another word for our EPSDT. In Wisconsin, we call it health check, and it has to be prescribed by a physician. So there are these services like outpatient psychotherapy and substance use, which are generally some across prescription, and then some of these more intensive services begin to become more limited and are really at the discretion and dependent upon your physician or upon your enrollment in specified programs. Next slide. I included this as a resource that was shared with us through Primary Healthcare Association, which I will leave it in the slide presentations to just think about the service array as moving from limited patient autonomy all the way to complete patient autonomy, and across different kinds of services. I appreciate this presentation of how the continuum of care looks. We talk a lot about the continuum of care in the presentation today, and I think it's the way that we think about the array of services that need to be available throughout sort of that mental health recovery, substance use recovery journey, and that there are early stage supports that can be provided to people. We move all that way from prevention all the way to, residential services, and think about all the places and ultimately with this chart landing in incarceration. And that's one of the things that I appreciate about this presentation, is that it is looking at that reality of where some of our mental health services are delivered in the state. Next slide. Let's talk a little bit about psychosocial rehabilitation programs specifically. We've referenced some of these the program today, but comprehensive community services, community support program, and community recovery services. I just wanted to include here to show a little bit of a snapshot picture of how the financing looks differently across these three. These are programs that people access again through functional screen through their counties primarily. Many counties operating in consortia for the delivery of comprehensive community services. All of these are Medicaid eligible Medicaid programs. And that there is Medicaid drawdown happening through the feds. But you'll see that with CCS, for example, the expenditure that's shown here for 2019 and 2020 at $214 million. And that there's really no county component in that. And contrast that with the community support program, where you will see some county component that's being brought to bear in order to draw down those federal dollars. Next slide. This one is really provided, again, it is not referencing Medicaid funded services specifically, but talking more about the broad-based county service use. So as counties think about their service delivery, I think the important thing to note here, and these are dashboards that are available on the DHS website, I think just to note how I would say the intense utilization of crisis services relative to other services that counties are able to support through the array of programs that are provided for mental health and substance use through our county delivered systems. Again, crisis really used to a large degree, and really thinking about the question that poses about where we really want to see the focus for our service delivery. Next slide. Just a very quick take on the where of the services. We've talked a little bit about the payer stream, now thinking about our county-based psychosocial rehabilitation services, thinking about our MCO services delivery and enrollment options. Now we're actually thinking about the where that people receive these services. And so this is the array of thinking about the locations, right, of where the providers are located. And so you're going to have Medicaid eligible providers operating in hospitals and clinics, in state operated facilities that we think primarily about Winnebago and Mendota Mental Health, community health centers like the federally qualified health centers, schools, behavioral health and substance use treatment clinic, as well as private practices, crisis facilities, community-based options like in-home and respite service providers, peer recovery homes, telehealth. So all of this is the where. Next slide. We really wanted to get to these last two graphics to wrap up, and there's a lot bundled here. So a lot of good questions about, will I get these slides? And yes, we will be sharing out this resource, but really, there's just two slides here. This first one is really looking at the adult continuum of care, and it's a struggle to provide a solid representation. And we were able to receive one for that DHS had put together on the children's side, and so we mocked up a similar one on the adult side here. We'll think about across the array from preventative all the way to crisis services, what the level of acuity is for the individual in each of these phases. And then those gray arches in the middle really start trying to define like the where of the service, like who has a handle in this, who has a part in this. So you'll see that move from sort of that clinic space, SQHC representation, some counties, hospitals at those different arches and levels, and all the way to the very high acuity services, all the way to crisis and thinking about emergency rooms. So I think this is one of the best visuals that I've seen to try to sort of really represent where you're falling along that continuum and what kinds of service, and whether it's currently available or if it's under development for availability. Next slide. So again, a similar picture for our children's behavioral health continuum of care. And here again, only on those Medicaid funded services. So that's another piece of this that's really important to think about, is where Medicaid is a player. That's what's represented in this chart. So you'll see all the way from that early prevention to when we look at high, and again, we'll provide a chart that's going to provide a crossover for these, a glossary of terms for some of these acronyms. But all of these are the Medicaid array, and then some coloring and differentiation for where we may still have service gaps, where we have services in development, where we have some existing benefits. I think with that, we're ready to move to questions. Discussion. Oh yes, we did have one more slide. So where are we going? So I think, don't want to drop off on this one. We had said earlier that there's a lot of flexibility for states about how we actually design our program. So this is really just talking about where we see opportunity. And so I'll quickly tick off a few things here. This question of how we actually provide for access really is contingent to a large degree on full reimbursement for providers. We will not have providers jumping into the systems, enrolling in our networks, actually providing that access if they are not receiving adequate reimbursement for their services. We need a progression toward continued reduction in reliance on county funding. Again, we note that it's a big equity question across the state, and to the degree that Medicaid is becoming forward as a bigger payer piece, it helps to create greater equity and access across the state. Expansion of coverage for evidence-based practices. As we noted previously, Medicaid is a driving force in innovation. And so it really is an opportunity for us when we think about how we fund those evidence-based practices and ultimately improve the outcomes for individuals, which is really what we are all seeking to achieve. As we provide for coverage and access, we want to really make for a better quality of life for the individuals receiving the services. And then finally, just a note around for the more intensive end, that we are on a path to move towards approval and implementation, hopefully, of the IMD waiver. That gets in, again, some alphabet soup, but basically covering psychiatric hospitalizations in a way that we will be able to get people better access to hospitalization when that is needed. And so I'm going to leave it there. And so we can, I don't know how much time we're going to have to go into groups. We could probably leaving it to Sita and where we want to go next.
Okay, I think what we're going to do is just go straight into a whole group discussion. I'm going to put some questions in the chat and I will read them aloud. So you know, both your personal understanding of Medicaid and then thinking about how can you communicate to people in your networks, whether it's your organization and your staff or NAMI affiliates or your clients or you know, anybody, you can understand how important Medicaid is for mental health. So the questions are, how does this slide help you tell the story of Medicaid funding in Wisconsin and why it matters for mental health? And we'll send these slides out to everybody. Please take a look and say what's confusing, what should be emphasized, what should be removed, like it's a little too much information. And how might you share this information with others, like your clients and colleagues and policymakers? And I see Sandy has a question to start us off. How can we help those who were disenrolled from Medicaid after COVID? Do we have people in each county who can work with those who were dropped?
Thanks, Sandy. I can get back to you on that, but yes, there's a lot of, well, maybe not a lot, but there are resources for helping people with that.
And then another question from Mary Kay, how do we direct legislation to Medicaid reimbursement to community services to decrease the need for so much crisis care?
One of the things we didn't jump in on today, and hopefully for you all who are in our MHAP community here, we are working in our Medicaid work group. We have a number of recommendations, and certainly that issue around the full funding of services is important, and it's important across all of the service array to make sure that we're adequately funding each of the components. I think we get misuse of our services and underutilization and overutilization when we have that differential way that we're paying for service that is. So really getting to providing for full funding in all of the elements across the continuum is an important objective. So yeah, I mean, the question of the how, for the convincing legislatively around that. I think part of that is, we know that the expenditures, and so I think there's more data work. We certainly are recognizing there's more data work to be done to be able to show where we are, where there's just some of the costs that we could be shifting to or upstream, and really helping to actually create better quality of life for people, and reducing some of our costs by spending earlier.
Yeah, so as you're saying, Kathy, early intervention is the key. So that's like school-based services and early intervention in psychosis and screening through your primary care physician or your federally qualified health center, that sort of thing, and helping people who have serious mental illness get the full community support program, which is an intensive wraparound program, rather than getting eked out on services that aren't at a sufficient intensity level to meet their needs. Rick.
Thank you for really an amazing presentation, both of you. What I'm coming away with is there's so many different sectors, if you will, MCOs, family care, flavors of family care, counties, school-based services. Has there been any discussion that you're aware of really looking at the overlap or lack of overlap of these services? In the past, I think early in the family care development, there was a Blue Ribbon Commission in the 90s. There was an effort to look at county-based services, but also PMG report from 2009, 2010 looked strongly at opportunities in Medicaid. And it feels as though we're kind of overdue for a really comprehensive look. So are you aware of any effort, the level of DHS to do that?
So I think it's really an important question structurally, Rick, for us to be thinking about. Certainly, that's why we're invested organizationally, and the MHAP effort is to make sure that we're putting that conversation front and center. There's been a lot of progression and change over time since that 2009 TMG study, and think about the growth and expansion of comprehensive community services, for example, the changes that are happening in the federally qualified health centers around integrated care. There are definitely movements happening within our Medicaid programs to make advances in the design and the array of things that we're covering. I think about interpretive services just being approved. So you do see progression happening, but I think that to know that we have a comprehensive strategic plan about where we are going as a state, that's a separate question. And I don't, so I think it's really incumbent on all of us to be asking those questions from an advocate perspective about how do we really get to what's next, because we're not spending our resources as smart as we can, and it's not really delivering us the benefit that we want to be achieving for the people who we're covering under these systems.
Yeah, I entirely agree with Kathy. From our side with federally qualified health centers, or even tribal health clinics, it's really been our own kind of advocacy with DHS, and I think this community is that place where we can kind of have a broader ask and a broader vision, because I think that just hasn't quite happened yet. So thanks, Rick, for that question though too. I think it's really important.
And I would add to that, the more that we talk amongst ourselves and find out what we're clear on and what we're confused about it from the other person's perspective or the other organization's perspective, and the more we can kind of sing off the same song sheet, the more progress we'll make. So I think as we talk amongst ourselves and have these in-depth conversations, then we'll come to a sense of what we need to ask the Department of Health Services or the governor or the legislature for. And then Brad, I wonder if you would articulate your question about rates for services.
Yeah, so off the top of my head, we looked at basically the cost of a week in St. Mary's Hospital here in Madison for psychiatric care would pay for a full year's service for someone in our psychosocial rehabilitation clubhouse program. And it looked like to the point earlier too, that the crisis prevention or crisis stabilization services are funneled. Kathy, I loved how you use that funneling analogy to talk about how difficult it is to access some of these services. There's two, and the other thing too is if you can provide those services within the program where you already have a therapeutic relationship with somebody, you're going to draw them into that, and you're going to know kind of what supports they need too. Every time we refer somebody else to a new service, there's intake stuff, there's this, there's that, and it's inefficient and I think not a great cost. So if we had figures like the total amount spent on crisis stabilization versus the total amount spent on community psychiatric hospitalizations or Winnebago hospitalizations, maybe that starts to get people's attention a little bit more.
Yeah, that's a really excellent point, Brad. And I think Sashi is saying, keep those stories coming. So as we are developing these materials that you can use to present to others. So think about other things that would be helpful. For instance, a glossary, examples like this. If you can tell us examples of, how much does it cost to deliver X care versus X care, and where is the savings? And not only where is the savings in terms of money, but how can it improve somebody's quality of life? That's really the most important thing.
Yeah, and I just wanted to jump in, Sita, and reemphasize Brad's point, because I think it's so important about this.
Your sound just went out, Kathy.
And
You start over again, Kathy. Your sound is, yeah. No. Okay.
Right, well,
right. Oh, now we can hear you.
okay. So I just wanted to reemphasize. No. Okay, well then I'm not meant to talk.
Okay. But,
Put it in the chat, Kathy.
yeah, put it in the chat. And Abigail was saying the average cost of a hospital psychiatric stay per day in Wisconsin is $2,774, and the average cost of one night for one guest at the La Crosse Lighthouse Peer Respite Center is $400.
Yeah.
So
Yeah.
FYI, those are two inpatient or overnight safe places to stay, and you compare the cost. Rick.
Just a quick story. I've had the privilege of working in 2 different states, and one of the states in the late 80s, early 90s had twice the per capita use of state hospital beds compared to Wisconsin. And they were wondering why. And one of the factors appeared to be the Wisconsin PAC model, which should be implemented through CSP across Wisconsin. What they did as a first step was increase the rates of county and community hospitals to accept people under commitment and treat them locally rather than ship them to the state hospital. In 3 years, there was a 30% reduction in state hospital bed use. That state is now half the adult per capita bed use compared to Wisconsin. And they used the state staff, which were AFSCME, and retrained them in the PAC model to serve folks in the community. I think that's a nice example of using evidence-based practices and Medicaid innovative strategies to really shift inappropriate use. And I also put something in the chat about our rates of incarceration and the costs locally. Thanks.
Yeah, it really comes down to the saying, the right care, including high quality, the right care at the right time, in the right place, helps the person and also helps the system. So it helps the person have the best quality of life possible and helps the system spend money in the right places. We have
one other.
Go ahead, Rick. Yeah.
Very quick. I just want to acknowledge Dr. Pam Lanow, who I think is on, who I believe and her small team have been amazing during the pandemic. transparent, innovative. My concern is that when I did a comparison of administrative funding for the Division of Medicaid Services in this neighboring state, theirs was about 800 million and a budget, Medicaid budget of about 13 billion. Ours is about 10 billion, but at half the administrative budget. So as we're looking at the changes that need to occur, I think we should also consider the resources that the Division of Medicaid Services has to do the job.
Yeah, very good point. And Dr. Lano, we're delighted to have you. I don't know if you want to say anything at this moment since we've called you out.
Number one, I think that's a great observation, and it is an observation that has made it on the radar of other folks recently about administrative funding. And then also, I'm going to do a shout out to Nikki Moore. She appears as Catherine Moore here, who created that visual of the children's continuum of care, which we found extraordinarily helpful. She's here in the meeting too, and we were both like, oh my goodness, we've seen that before, and love your adaptation of that as well. There's so many good visuals here. So just, I think you've done a fantastic job, Sashi and Kathy, explaining everything. I'm sitting here listening, and nodding through the whole thing, because the information is so good, so accurate, and also presented in such an accessible way. And I feel like information is power. So helping, the more people understand, the more they're able to figure out where they can plug in and leverage and start to make a difference. And just very much appreciate your efforts here.
That's wonderful. And thank you so much coming from you. That means a lot. So everybody, we're going to wrap up on this Friday afternoon. Like I said, we're preparing these materials. If you would like to be a presenter, or you know someone else that you would like to recommend as a presenter for these materials, please have them email Julia, and she's going to put her email in the chat, Julia Polk with NAMI, Wisconsin. And then we'll host a Train the Trainer session later in the summer. There is no learning session. We often hold these monthly, these learning sessions monthly. There's no learning session in July, but our next learning session will be on Friday, August 16th, the topic to be determined, and we will send the information out to all of you. And if there's something that you would like to learn about, or you think that we as the mental health community need to learn about, please email your suggestions to Julia. We're collecting those. There's a core group that kind of helps keep all the plates spinning for the Mental Health Action Partnership. And we would love to get your suggestions on what we need to tool up on. We mentioned work groups, the Mental Health Action Partnership, the Action Partnership part of this, and the partnership part of this are very important. We have work groups that are developing recommendations, like policy recommendations and talking points to help improve the mental health system over the long haul, the short haul and the long haul in Wisconsin. So if you're interested in joining one of the work groups, please email Julia. The 4 work groups at this point are Medicaid. So we're developing policy recommendations around Medicaid. Workforce, we're developing policy recommendations on how to strengthen the workforce and expand the workforce and keep the folks, having quality of life who are working and delivering these services. And then another one is diversity, equity, and inclusion. Not only who should be at the table in MHAP, but how the mental health system needs to serve underserved, diverse populations throughout the state, and what strategies could help our system serve those populations better. And then we have a governance work group, which is how MHAP governs itself. And there are a couple of other work groups in the cooker right now to be determined in the near future. But if you want to be one of those, part of one of those 4 work groups, please email Julia. We would love to have you. They meet online approximately monthly, or and so we would love to have you.
Glad you joined.
Yeah.
And then finally, mark your calendars for our next MHAP in-person summit. We had one May 22nd, and our next one will be October 16th. And we know everybody's calendars fill up, That's a Wednesday. It'll be from, 9 to 3, something like that. And it'll be in southeast Wisconsin, somewhere in the, Waukesha, Milwaukee, Racine sort of area. So mark your calendars for yourself. And if there's someone else who you think needs to row with us so that we can all speak in a unified voice to the decision makers, then please refer them to us through Julia. And I think that's it for announcements. Julia, am I missing anything? No. All right. Well, have a wonderful weekend, everybody. I don't know about you, but it is raining cats and dogs right now, so I miss the sunshine. I'm just going to have to put up an umbrella and head home. So thank you, everyone. Have a wonderful weekend.